Another case that we had, this was a pre-pontine lesion, hyperintense in T1 weighted sequence. Now, when we did the spectroscopy, we saw something unusual. We saw a large peak at the same place, near the 2, at the same place where we should have seen N-acetyl aspartate, a neuronal marker. But why should there be neurons in this region? That was the question. So, we took the sample of the fluid after surgery, and when we analyzed it, we found out that it is due to N-acetyl sugars, glycosamine, galactosamine, which are responsible. So as you know, it does not give an information about a particular chemical, but rather the moiety in which it is there. The N-acetyl moiety is the one which gives a spectra at the 2. So that is how we could find out, and this has been published. And later on what we have seen, this is seen in most of the lesions which are lined by ciliated columnar epithelium. And we have found out the same thing in the bronchogenic cyst. And there was a recent report, which has not been yet published, that even mucinous metastasis within the brain can have a high Na like that. Within the mucoceles, where there is a large amount of mucous material, you can have this large peak at the Na, because it is not actually Na, it is N-acetyl sugars. 61-year-old female, a doctor, with a lesion like this. Is it a glioma or anything else? Now today the first thing we would have done is a perfusion imaging also in this, because perfusion imaging helps, as I was telling you. But whether it is a low-grade glioma or whether it is a tumefactive demyelination, yet it might not be very helpful. In some cases, some of these cases, spectroscopy helps, because usually in tumefactive demyelinations, you have a large lactate, as well as the choline is not very much increased except at the margins of the lesion, where it is enlarging. The tumefactive demyelinating plaque is enlarging. In those areas, you can see a high choline, but usually within the center of the lesion, the choline is not that much raised. So that was a case of tumefactive demyelination. This is another case of a patient with, after surgery, there is a lot of enhancement within the lesion. The question, it was also showing restricted diffusion. So is it due to high cellularity, or that is a tumor recurrence? Now, we do a spectra, we see that there are no areas of choline increase, and there is only what we see, a large lipid lactate peak. So when you see such things, you can be very sure that you are dealing with radiation necrosis. But remember that radiation necrosis can always coexist with tumor recurrence. So you should again look at the multivoxel spectroscopy, look at areas where there is high choline, and look at areas where the choline is low and the lipid lactate peak is huge. So these things have to be remembered. And also very important, perfusion imaging is a very good technique in differentiating between these two conditions. So that was a case of radiation necrosis. Now this was the case which I was talking about. This patient had a lesion here which showed a big lipid lactate peak. And we know that tuberculoma can have a large lipid lactate peak. Metastasis can also have a large lipid lactate peak. How will you differentiate these two entities? So this was a problem for us. We were doing a lot of cases. Then we started doing perfusion. And what we understood is that perfusion is the best technique. But then there are fallacies, as I just now told you. Some of the tuberculomas sometimes can show a high perfusion. This case, ultimately, what we diagnosed, because it's a young female, we diagnosed as a tuberculoma, but turned out to be a metastasis. Lipid lactate peak can be seen in both. In infections, it has a big role, actually, pyogenic abscess, and there are papers from SGPGI which have tried to differentiate between anaerobic and aerobic. We have not gone to that extent because it's slightly difficult and we may not be able to give very consistent results on that. But if you see a large peak at in the lipid lactate as well as amino acids, alanine, succinate, then you are most likely dealing with an abscess and not a tumor. And also, if similarly in racemose cysticercosis, if you get a large succinate peak, you are dealing with cysticercosis. Sometimes you don't see any of these things, just see a large lactate peak. These are chronic sterile abscesses. You don't see much amino acids, you don't see succinate and choline. So whenever you do of infections, better go for a low T as well as a intermediate T of 135. What about neurodegenerative diseases? Yes, it has a role in multisystem atrophy, because what we have seen is Parkinson's plus versus Parkinson's plus syndrome, in differentiation between these two entities, it might be useful, because in Parkinson's, usually in the basal ganglia, if you put a voxel, there won't be much difference in the choline and the NA. But usually in cases of Parkinson's plus, both multisystem atrophy as well as supranuclear palsy, now both these conditions, you can see that there is the Na drops down. And also, as Bijoy was showing you, there is a lot of mineral deposition, which usually Parkinson's diseases does not happen. In epilepsy, it has some role, because some cases which are indeterminate and you are not sure whether MTS is there or not. In such cases, what you can do is you can do a spectroscopy, but you should remember that the head, the body, and the tail of hippocampus behaves differently. The head shows an equal amount of choline and Na. As you come towards the tail, it becomes the normal. The Na is more and the choline is. So when you are comparing, you should know this particular finding. We have done it in cases of MTS, and we have some of the cases which is having a problem. We have been able to tell which side is more involved, or cases where it is indeterminate by the conventional imaging, the spectroscopy helps. The major problem with spectroscopy of temporal bone is because you are looking at a structure which is very near the temporal bone. And what we have found is, rather than going for a spectroscopy, it is the T2 relaxometry which is much better in looking at this particular finding. So, any questions in MTS, or should I go to the next? So, on spectroscopy? Question.